Okay, let's finish up the little bit of chapter 11 that we didn't quite get to in class. So, as we about what we've done so far, we talked about structure of the private insurance industry. We talked about the history of that industry and the importance of private coverages and what fraction of our population is covered through private insurance. We talked about the variety of types of insurers, concentration of the markets, and barriers to entry. Then we started to review the conduct of the industry, how a firm gets to be dominant, talked about the dominant insurer pricing model. We reviewed premium setting and loss ratios, and we talked about adverse selection. We're going to wrap up the conduct segment with a review of a couple of concepts called cream skimming and shadow pricing. We're going to talk about monopsony power of insurers as they purchase healthcare services from providers. Remember, a monopsony is when you have a single buyer as opposed to monopoly when you have a single seller. And then we'll look at the performance of the industry. We'll look at moral hazard, which is an important influence on premium levels. We'll define the difference between ex ante and ex post moral hazard. We'll look at trends in premiums over time. We'll look at the fraction covered by private insurance over time. We'll look at those who fall through the cracks, the uninsured, and what different categories of uninsured individuals exist. And then we'll look at the history of 3 major pieces of legislation that tried to improve the performance of the industry. So let's go back to conduct and talk about conduct of MCOs, or managed care organizations. That's shorthand for that group of organizations that includes PPOs, point of service plans, and HMOs. Do these managed care organizations cream skim the healthiest patients and shadow price traditional plans? So in a market where you have traditional indemnity plans where there's not a lot of network incentives, and then you have managed care organizations also, typically when you have tighter networks and more steerage through cost sharing into the networks, the people who are healthiest are the ones who are willing to accept the tightest networks, and the people who are sicker need broader networks because they may want to access a broader segment of providers. And so managed care organizations keep the claims payment piece. The theory is they keep the claims payment piece of their premiums low by cream skimming, that is, attracting the cream of the crop, the healthiest people. And they can't do that anymore through underwriting standards because of ACA, although they historically had. But they still can use plan design and network design to attract healthier patients. For example, in plan design, you might offer wellness benefits. You might offer subsidies for going to the gym, things like that, that presumably attract people who tend to be healthier because they're the ones who are showing up at the gym. Or you might offer a network that really focuses on great OB-GYN services because that tends to attract the younger people in childbearing years, but really lean cardiac and cancer care provider network, just enough to be sufficient. And you may not have marquee players in that segment of the provider group. And that would tend to discourage people with cardiac conditions to enroll in your network, but encourage the young childbearing age families into your network. So there are really subtle ways you can market yourself and get cream skim even without underwriting practices. And so that cream skimming keeps the payout portion of the premium lower. Remember, payout plus forecast error plus admin plus taxes plus profit is the total premium, and it's the payout piece they're trying to keep low. Shadow pricing is just shadowing the price of your competitor. So if you've got a traditional indemnity plan in your market that's charging $300 a month, and you come in and you price yourself at $275 a month, that's shadow pricing. You're not using the perfectly competitive standard of price equals marginal cost, because price is your marginal revenue. So marginal revenue equals marginal cost is where you price yourself in a perfectly competitive situation. Shadow pricing elevates the price to the amount just below your competitor, and that allows you to capture economic profit. Lawrence Baker is a really well-known a well-known researcher in the area of healthcare marketplaces, and he has done some research in this area, and he found that The more managed care organizations you have in a market, so if managed care sells 80% of the plans versus 60% of the plans in the market, that's what I mean by market penetration. The greater the penetration, the lower the premiums for managed care. And you'd actually expect it to work the other way around. You'd expect that when they have shallow penetration, they're just scooping those healthiest patients, and so premiums would be really low. But as they got deeper penetration, they're taking a broader spectrum of the people in the area, and so their premiums should start to get higher as the risk mix gets higher. So that indicates there's probably shadow pricing going on, because if the MCO just has 30% of the market and the rest of the market is that indemnity plan, then the MCOs can, if they're shadow pricing, can be right up there. But then as competition, as they get deeper into the market and things get a little more competitive, then their prices come down. Okay, let's talk about monopsony power. Now remember, in this case, the insurer is the purchaser, not the seller. So we're not talking about selling insurance, we're talking about buying, in this example, hospital services. So we've got our graph here with a supply and demand curve, and the supplier is the hospital who's supplying inpatient days. The purchaser is the insurer, and that they are the only buyer, so that market demand is the individual buyer's demand, that individual insurer's demand, and it represents the insurer's marginal benefit. As you move down that line, it shows the amount they'd be willing to pay for one more incremental day of services purchased on behalf of their covered individuals. Think of inpatient days as an input in the production of insurance. Okay, so now let's talk about what marginal factor cost is. So this is the marginal cost. Remember when we talked about monopoly power, we had marginal revenue that was same as the demand curve but had a slope twice as great. Marginal cost from the perspective of the insurer is the same as the supply curve but has a slope twice as great. And why is that? Well, I'm the only buyer in the community. So if I buy, say, 10 days, hospital days, and each of those hospital days costs $300, say I want to buy an 11th day. Well, to get the hospital to sell me an 11th day, I have to raise my price a little bit. So I raise it, I just lost track of what price I said. Did I say 10 and $300? Say I said 10 days with $300. If I want to move to 11 days, maybe I have to bring my price up to $350 to get that 11th day. Not only do I have to pay $350 for that 11th day, which is represented by the supply curve, but I have to go back to those other 10 days and pay that extra $50 for all of those guys too, because there's only one market price. So if I raise my market price to get that 11th day, I'm paying that same price for all 11 days. So my marginal cost of buying that 11th day is the $350 for the 11th day, plus $50 for each of the other 10 days I'd already bought, because I got to go back and retroactively raise that price too. That's why the marginal factor cost is higher than the cost at the supply curve. And so marginal cost equals marginal benefit right there where that burgundy marginal factor cost line intersects the demand line, because the demand line is the insurer's marginal benefit, and that burgundy marginal factor cost is the insurer's marginal cost. So they're equal at the intersection, so that is the quantity that the insurer wants to purchase. To induce the hospitals to produce that many days, I only have to pay P star. I read price off of the hospital supply line. Okay, so that's similar to, it's backwards from, but similar to what goes on in monopoly power. And just like monopoly power, we have deadweight loss, welfare loss, because you've got a period there where you're not buying. You don't go all the way up to the intersection of supply and demand. You buy something less than that. And in between those two quantities, you're in a situation where the insurer would have valued, according to their demand curve, they would have valued the benefit of buying that additional day more than the cost of the hospital purchasing or producing that additional day. And so that creates welfare loss. Okay, so these are the results we expect from that graph: that price is below the competitive market price, that there are fewer inpatient days purchased than in a perfectly competitive market, and that there's a deadweight welfare loss of monopsony. And so the question is, does monopsony power really exist? What did the empirics tell us? Well, when in the studies that they've done, it really looks like when you do a review of that literature, it looks like price tends to decrease as expected, but Q does not. The quantity sold does not decrease. It stays relatively stable as the insurer concentration increases. So those results actually support the theory that insurers are consolidating and gaining monopsony power to counteract the concentration on the hospital side. Hospitals are concentrated and are sometimes the only or one of a very few sellers of inpatient days in the market, and so they have monopoly power, and the insurance companies, by consolidating, get a counteracting monopsony power. And so those two things are, the insurance concentration actually is monopoly busting, or it disentangles the effect of having a monopoly, because you've got these two large entities negotiating now. And that's what they think is going on based on those empirics. Okay, that's conduct. Let's look at performance of the industry. We know managed care organizations compete on price. Price is controlled through minimizing the loading fee, that is the forecast error plus admin plus taxes plus profit, by negotiating provider discounts, and so that was the monopsony power, or the insurance consolidation and the power they have negotiating provider discounts that we just looked at in the previous slide. And finally, controlling utilization, so trying to counteract moral hazard. And that's an important part of that competing on price. So let's look a little more closely at moral hazard. We talked in chapter 6 about what utilization controls are used. I'm not going to go over that again, but let's look at moral hazard a little more carefully. We know about the price effect of insurance. So when you have insurance, then I, as an individual covered employee, see a reduction in my price, and when price goes down, my consumption goes up. That's called ex post moral hazard, because it is after or post the need for services appearing. When I choose, after I have chosen to seek care, I will seek more care because the price is reduced. Ex ante, that is before the need for services exists, ex ante moral hazard also exists. The ex ante story is about taking preventative action. So making sure you go to the gym, making sure you eat healthy, making sure you get your physical, and all of those things, those are ex ante preventive actions. And if you know you can rely on insurance to pay the cost of an illness, you may be less careful to prevent those illnesses. It's really a trade-off between consumption of preventive services and curative services. Insurance reduces the cost of curative consumption. And just like choosing to go bowling versus going to a movie, if one gets cheaper, you shift some of your consumption from, say, bowling gets real cheap, you shift from movies to bowling for your entertainment. Likewise, in production of health, if the cost of curative consumption goes down, then you may shift from preventive to curative consumption. But there are a lot of arguments against the existence of ex ante moral hazard. First of all, not all losses that are due to illness are financial in nature, right? We've got pain and suffering. We've got financial losses due to lost income that are not covered by medical insurance. There are a lot of reasons why you would want to continue to take preventive action to avoid illness. Another argument is that insurance increases access not only to curative services, but also preventive services. You can get your flu shots, you can get your physicals, you can get your mammograms, things like that. You can take the pharmaceuticals that prevent complications from high blood pressure and cholesterol, and you can take your diabetes medicines because you can afford them. So there are a lot of preventive services that are facilitated by insurance. Both insurers and employers support wellness activities, so the presence of insurance and employers need to minimize their cost of insurance. Both the insurers and the employers want to minimize future costs, and so they support wellness activities. Prior to ACA, future insurance premiums would also be affected by lack of preventive action, because if I get sick, it's harder for me to get insurance or harder for me to get affordable insurance in the future. So that was a disincentive for ex-ante moral hazard. Finally, curative services can't always get rid of illness, right? So you get, say you have a heart attack, you can go through rehab, but your heart will never be the same. On the other hand, preventive services, taking your cholesterol meds and making sure your blood pressure stays low and losing weight, those things can completely avoid the heart attack in the first place. And so you're better off net net. Let's go back to ex post moral hazard, where we see increased consumption because the price of insurance goes down. So the low cost sharing means patients don't have a strong incentive to really stop and think about their purchasing because they're not paying the cost of it. They just go do it. So historically, patients rarely have questioned the doctor's recommendations. Now, there's a lot of other things going on there too. There's informational problems. The doctor knows more than you do about healthcare and so on. So there's that there too. But the low cost means you just don't examine it quite as carefully. Maybe you don't shop around quite as much for a lower cost option. So that's one implication. Another implication is the Nyman's theory of access, right? So insurance leads to access. I wouldn't be able to even get to this technology or this fancy care if I didn't have insurance. And so insurance gives individuals access to technology. That leads to an increased market for technology producers, which leads to greater investment in research and development to develop more sophisticated technology because there's a market for it. And the whole cycle begins again, because now that you've got this even fancier technology that's even pricier that you have to have insurance to get, and so on and so forth. Because of this, technology is one of the biggest drivers in medical trend. Now, I don't want to be dissing moral hazard the whole time. Remember Nyman's concept of efficient moral hazard. If insurance gives access to care, then that access might cause efficient increases in consumption. And an efficient increase in consumption happens whenever the patient's marginal value of that benefit exceeds society's marginal cost, right? So if I couldn't have accessed the pharmaceuticals I needed to take care of my cholesterol because I just couldn't afford them without insurance, now I have insurance, I can get them. Society is better off because I am taking my preventive meds and preventing a future catastrophic illness. And my value of preventing that exceeds the relatively small cost of pharmaceutical coverage. Value-based insurance design, which we discussed briefly early in the year, leverages this efficient moral hazard concept to and they leverage moral hazard to incent efficient services, consumption of efficient services, by reducing the cost of those services. So I might eliminate the copays for preventive medicines and for preventive care and cancer screenings and things like that. So either eliminate the copays or reduce them greatly. And the Affordable Care Act actually took that to heart. When the Affordable Care Act was passed, preventive services are now free. That includes contraceptive coverage. Controversially, that was categorized as preventive services. And of course, some faith-based organizations are concerned about supporting contraception because that violates some of their beliefs. And so there are some exemptions to that for religious institutions. Little digression there. So as we continue to talk about the conduct, or the performance of the individual insurance industry, let's look at premium trends and what's happened to the growth in premiums and the cost of coverage over the years. This is a chart straight from your book. The real premium per insured is there, and the bar chart piece of it, that is we've neutralized the difference between a 1960 and a 2010 dollar, so that's what they mean by real premium. I find the dotted line more informative. That's premium as a percentage of income. And you'll see that beginning in 1960, and remember this is after the expansion of coverage through World War II and the increase in the power of unions, it still was fairly cheap, probably $500. Looks like it's about $500 in real dollar terms. Grew steadily throughout the 60s, 70s, and 80s, and then we saw a dip around beginning about 1993 into 1999. You see that big pronounced dip there in the late 1990s. And this was a period of time where there was a real strong increase in HMO penetration. And so those HMO plans, remember, are the ones where you have to be in network to get coverage. So it gives you the ability to have tighter utilization controls because it's only in network services. And it gives the ability for the insurance company to negotiate deeper discounts because you're for sure steering the patients to that provider network that can't go out of network. And so the insurers were able to get really deep discounts. Then there was a backlash against the HMOs, probably in 1990 to about 2005. And during that time, there was a movement to the more open network plans, the PPOs and point of service plans. Actually, over the course of that period, PPO enrollment went from 39% to 61% of the market, the private insurance market. So you can see there was that big shift in the kind of insurance we had. And then as that shift happened, that's the big spike in growth between about 1999 to 2005. Things flattened out again after that as there was more conversation about health reform. We see another big jump right up until 2010. And you see 2009, 2010, things flattening out. And I wish this graph went out further because you would see that things stayed really flat, just unusually flat, since from 2010 through about 2015 or so. Now in 2016, we're starting to see a resurgence in medical trend, but for that half decade, things were really flat as the Affordable Care Act was put in place on a per capita basis. Costs were very stable in the private insurance market. One of the things that your text will ignores as they analyze this growth in premium is the richness in plans over time. So one of the things that's happening is proportionately in 1960, people were paying a lot higher fraction of claims through deductibles and coinsurances. And now we have all of these point of service plans where we have a fixed dollar amount for office visit coverage and a fixed dollar amount for pharmacy and maybe a flat deductible for per admission going into the hospital. So we're paying actually outside of those high deductible health savings account plans, but for normal plans, we tend to pay a lot less than we did in the 60s and 70s in terms of percentage of claims. There's also been a huge spike in the value of insurance because of the technology available through insurance. So what you're buying, the mix of services you're buying has changed dramatically since 1960. And so it's almost unfair to make this comparison because you're not buying the same bundle of goods. So as you analyze this graph and think about skyrocketing costs, remember the market mix the bundle of goods has changed as well. That's not to say that our costs were in control and all of that growth is valuable growth, but just moderate your assessment of this, knowing that there's been a change in technology as well. When you're thinking about changes in premiums and how are things going, be careful about interpreting short-term premium changes. So if things flatten out or spike for just a year or two, don't overinterpret that. Wait. You really need to see a 4 or 5 year period to understand what's going on longer term with premiums. And that's because of something called the underwriting cycle. Insurers will periodically drop premiums and really reduce that risk margin in their premium development because they're trying to build market share. They'd rather take a risk on how much it's going to cost to build market share And then if they do if losses emerge because of that risk, then they have to spike in premiums back up in a year or two to recover those losses. And so what that does is it drives cyclical profitability. Insurance costs are hard to predict, and so the underwriting cycle is something that's real and been documented. How about private coverage? What's the scope of private coverage? Way back in 1940, before the wage and price controls of World War II, only 9% of the population had private insurance. And that peaked in the 1970s at 76% of the population. And that, of course, was just the under 65s, because by 1970 we had Medicaid for the older folks. By 2010, we were back down to 64% with private insurance, just prior to the imposition of the health reform. The post-ACA, we've recovered a little bit. About 66% are back to having private insurance. So what are the reasons for the decline from that peak of 76%? Well, not all of it is financially driven. Some of it's just the aging of America. Folks are getting old enough that they're moving from private coverage to Medicare, so they don't need that private coverage. But this high trend that we saw in the previous page's graph does cause a lot of changes. Employers dropped coverage often because they couldn't afford to give it as a benefit anymore, especially if they were working in a low-wage industry, and minimum wage capped their ability to shift from salary to benefit costs. If the employers themselves didn't decide to drop coverage, they might have instead shifted a large portion of the premium share to employees. So maybe the employer paid 80% of the premium, and now they're paying only 70% of the premium. So the employees have gone from 20 to 30. That's actually a 50% jump even before medical trend. And so the employees themselves decided to drop coverage. There's also just been shifts in the workforce and the kind of workforce we have. Been a big shift from manufacturing to service industries. And we know that insurance coverage is much more common in manufacturing than it is in service industries. Service industries tend to be lower wage, and that means benefits are less frequently offered. There's also been a shift from full-time to part-time employment. And with part-time employment, you can't afford to you're typically not eligible for benefits when you're in part-time employment. And then, of course, the Great Recession. In fact, from 2005 to 2010, there was a 5% loss in private insurance coverage, and some of that was driven by the 2008 to 2010 recession. All right, so if people are losing private insurance, we've got uninsured out there. We know about that, particularly prior to the implementation of the Affordable Care Act. Who are those uninsured? And so statistics I'm giving you here are all from 2013, I think. They're pre-ACA. But 27% pre-ACA of those who were uninsured were 18 to 24-year-olds. That's the folks that are in the gap between perhaps parental coverage and their own coverage. Prior to that, the extension of coverage to age 26 under the Affordable Care Act. We call those people frictionally uninsured because it's the friction due to a change in status from being a young kid on their parents' plan to an older employed and full-time stable job with their own coverage. Another group that is frictionally uninsured are people who are between coverages due to circumstances like a job change. So you may have been laid off. It takes you 3 months to find a new job and get insured again. And that would be frictionally uninsured. Then there are people who are structurally uninsured. They are, just by the structure of where they are in the population and in their life, they are too sick to pass underwriting maybe prior to the ACA reform, or the premiums were unaffordable prior to ACA providing subsidies. And those people are just stuck in a situation where they aren't going to be able to get insurance. We know that premium affordability is a big driver for uninsurance. 27% of those with incomes below $25,000 are uninsured, while only 8% of those with incomes above $75,000 were uninsured prior to ACA. It's clear that income has something to do with it. The third category, beyond frictionally and structurally uninsured, are those who are cyclically uninsured. They migrate in and out of insurance status. Maybe you have a seasonal job, and when it's in season and you have your job, you have coverage, and out of season, you don't. Or you are just on the border of Medicaid eligibility and you migrate in and out of eligibility. So you're eligible for 6 months and then you don't have coverage for 6 months, and back and forth. All right, we've got just a couple slides to end up the chapter, and that's going to talk about some of the legislative history in trying to fix some of these performance issues and access issues. The first step on our pathway to the Affordable Care Act was the Consolidated Omnibus Reconciliation Act, or COBRA, from 1985. This legislation applied to group plans with more than 20 employees. If you were eligible for one of those group plans, you could enter the plan with a qualifying event between open enrollment periods. So prior to COBRA, you had to wait until fall when the open enrollment period happened to sign up for insurance that would start on January 1 of the next year. Now, with the qualifying event, if you have some life change like a new baby, or you got married, or your spouse was covering the family but they lost coverage because they lost their job, you could cover your family through your job in between open enrollment periods. It also allowed people to continue coverage on the employer's plan. So it required the employer to let the person stay on the plan even after they left the company. Maybe I quit, or the employer fired me or laid me off, but they had to let me stay on the plan for 18 months to give me transition coverage while I was looking for a new job. I had to pay 100% of the total premium, 102%, their 2% administrative load to pay the employer for collecting the mechanics of collecting premium from me and extending coverage. But what I mean by total premium means if before I left the job, if the employer paid 25% of the cost and I paid 25% of the cost as my employee contribution, once I left, I had to pay all of the premium plus the 2% administrative load. But that's still cheaper. That gives me group rates as opposed to individual rates. So it's still cheaper than going out and finding it on my own. And if I had a health condition, finding it on my own might be unaffordable. HIPAA, the Health Insurance Patient I think it's Health Insurance Privacy and Affordability Act. Sorry, I couldn't remember that. 1996. Under HIPAA, once you had coverage, the plan had to be guaranteed renewable. They had to let you stay in the plan the next year. Once you had group coverage, I as an employer couldn't charge one employee more because they had a chronic condition than a different employee. That had to be the same. Once I had group coverage, when I left, I had to be able to buy individual coverage, guaranteed issue. Restricted how much an insurer could use a pre-existing condition exclusion. So maybe if I were pregnant, I could exclude pregnancy for the balance of that pregnancy, but I couldn't exclude all future pregnancies. Or if I had a heart condition, I could say, okay, I won't cover the related costs for 6 months, but after that, I had to cover it. One thing HIPAA didn't do was help with the total cost of coverage or guarantee issue if you didn't already have coverage in some form. So there's just a big gaps. And then the Patient Protection and Affordable Care Act, or ACA, as we more shorthandedly call it, of 2010, has staggered implementation through 2014. In fact, there are still a few things that aren't implemented. But it limited individual underwriting, created subsidies to help low-income folks get insurance. Medicaid was expanded in many states. We're still going to have trouble with people cycling between Medicaid and that subsidized private insurance. It's going to be administratively challenging, but at least they have coverage access. And we'll talk about that more in the Kaiser Family Foundation ACA summary lecture. So that is the end of this chapter.